Welcome to the Medications in Older Patients presentation. Today I'm going to spend a few minutes talking to you about the effects medications can have on older patients. We'll be covering the objectives, why this subject is important, and then I want to provide you with some resources that you may find helpful when you're trying to decide which medications older patients are more likely to have problems with. By the end of this presentation, I'd like you to be able to explain why older patients are more vulnerable to medication adverse events. I'd like you to be able to identify some methods to avoid these medication adverse events in our older patients. And then finally, identify resources to assist in optimal medication use in older patients. Some facts that I think are important to realize about older patients and medications. First, about 60% of older patients do have a medication that's on their medication list that it does not really include an indication. So we have quite a bit of medication overuse in our older population. Second, we know that older patients are twice as likely to go to the emergency room for an adverse medication event. So these medications actually do cause our patients some harm. And then third, there is a study out that shows the risk of frailty increases with the number of medications. Bottom line is older patients are more vulnerable to adverse effects from all medications. When we talk about adverse medication effects, I want to make sure that we understand how they affect older patients' function. I think about geriatric syndromes. Geriatric syndromes are a group of symptoms that older patients have, and some of the common geriatric syndromes that are affected by medications are cognitive deficiency, impaired mobility and falls, insomnia, altered elimination, altered nutrition, and anxiety. And we could also add depression to that as well. Let me introduce you to Mr. and Mrs. Harrison. Mr. Harrison is 92 years old and doing well. He's helped his 91-year-old wife since she had a stroke 8 years ago. He comments that she's much more sensitive to medications than she used to be. She had to stop several medications due to side effects. So why do you think Mrs. Harrison is having more problems with her medications and more sensitivity as she gets older? Is it because changes in absorption, distribution, metabolism, and excretion of medications occur as patients age? Is it because the drug receptors become more sensitive to the medications as aging occurs? Or is it because as aging occurs, changes occur in organ function that make older patients more vulnerable to side effects? Or is it actually all of the above? So those of you who answered all of the above are correct. All of these do come into play, and we're going to talk about each one a bit more. Pharmacokinetic changes really refer to what the body does to the drug. When a patient takes a medication, the first thing you have to do is absorb the medication. If it's an oral medication, we are absorbing it from the gut. Most medications are absorbed within a few hours, but in an older patient, oftentimes it takes longer to absorb that medication. So older patients still absorb the whole amount, but it just takes longer. This does cause some problems if you have two medications that you're giving that interact together in the gut. You may not get as much effect from either one. Another thing that can occur is once the medication is absorbed, it has to be distributed throughout the body. And we do see changes that occur that affect distribution. Older patients tend to have less body water and more body fat. Both of those issues will cause medications distribution to change. We also do know that we see changes in protein. Our older patients tend to have lower albumins than younger patients. Albumin binds to many medications. If the drug is bound to the medication, then it can't bind to the receptor. So therefore, if we give the same dose, the older patient's going to have more drug available at the receptor since they'll have more in the unbound form. Next, the drug is metabolized or eliminated. Metabolism often happens in the liver. Liver blood flow changes as patients age, so we do see that as liver blood flow changes, we may again see some changes in the way that drugs are eliminated and how the drugs are affected, what the concentration is in the body. We also know that many older patients take many medications, and those medications may either induce the liver enzymes to metabolize other drugs quicker or inhibit them to metabolize other drugs, so they metabolize other drugs slower. Either way, we end up with drug interactions that can affect concentrations of medication. Lastly, we know that many drugs are eliminated by the kidney, and the kidney does have many changes that occur as patients age. Those changes generally will cause a decrease in renal function as patients age, so we do also need to be aware that these medications will need to have dose adjustments to ensure that patients don't have too much of that drug to cause toxic problems. Okay, those are the pharmacokinetic changes. The other changes are pharmacodynamic changes. And when we talk about pharmacodynamic changes, that is what happens to the receptor, so what the drug does to the receptor. And what they have found is they've done studies where they give the medication to older patients and younger patients, adjust the dose of the medication so we get the exact same level, and we find that we still see more effects in the older patients. So in general, we feel that most receptors become more sensitive as patients age, although there are a few that become less sensitive. Another issue that can occur that affects how medications are handled in the body is that our older patients have less physiological reserves, and that really does cause them to be more sensitive to the adverse effects of medications. Just going through a bit in our brain, we see a decrease in cerebral blood flow, decrease in neurotransmitters, and a decrease in sleep efficiency overall. So if you have any side effects that are more central nervous system effects, our older patients are going to be much more sensitive to those side effects because of these situations. We also know that there are some changes that occur with both visual function and hearing function as patients age. Again, if there's drugs that affect those areas, more likely to occur in older patients. We can see changes that occur in lung function. We see a loss of lung elasticity. We see decreased airflow movement and an increase in residual lung volume. Again, side effects that affect the lung, older patients are going to be more likely to have those problems. We also see decreases that occur in baroreceptor response. We see a desensitization of the adrenergic receptors. So that's the one exception where those receptors actually may become less sensitive. So we may need more drug. We always start with a low dose because we're never really sure where we're at with our older patients, but just be aware of that. And we also see stiffening of the ventricles and the arterial walls. The kidney we already talked about. There is a decrease in renal blood flow, a thickening of the glomerular basement membrane, a decrease in tubular function, which all add up to decreased renal function. And as I said, we see a decrease in liver blood flow and what's more likely to have drug interactions in our older population. So all of these factors also increase our patients' vulnerability to side effects of medications. Back to Mr. and Mrs. Harrison. Mrs. Harrison states that she felt much better once it was determined that one of her medications was causing some of her problems and that was stopped. She also relates that after stopping that medication, she was able to stop 2 other medications. So, how do you think this happens? And do you think it's common? It actually has a term. It's called the prescription cascade. And the prescription cascade really comes down to being unrecognized adverse drug reactions. It's when we add a medication to treat an adverse effect of another medication. I have an example here. This is a patient that got started on metoclopramide, 10 milligrams Q6 hours. And the metoclopramide is a medication that increases gastric motility. So that is what this patient was using this for. This patient had some decreased renal function. So this is a high dose for an older patient with decreased renal function. And they did have a side effect. Side effect of this medication that can occur in any patient, but more often in an older patient, is Parkinson's type symptoms. So this patient did get Parkinson's type symptoms, was started on a medication to treat that, carbidopa-levodopa, 10-100 4 times a day. Carbidopa-levodopa is common medication used to treat Parkinson's disease, but the carbidopa part of it is used to make sure that the patient doesn't have the side effects from the levodopa. So levodopa needs to get into the central nervous system. The carbidopa prevents it from being metabolized before that into dopamine, which has many side effects, including nausea and hypotension are probably the two most common ones. This patient wasn't quite on enough of the carbidopa. You need 75 milligrams per day to prevent that drug to be metabolized before it gets into the central nervous system. So in this patient, they did end up getting some nausea. We gave a medication called promethazine, 25 milligrams Q6. Promethazine is for nausea. Has anticholinergic effects, so not well tolerated in older patients. They often can cause confusion, constipation, urinary retention, falls. So this particular patient did end up with some confusion, got admitted to the hospital, and ended up getting started on a medication for dementia, although this patient, probably their confusion was more due to delirium. So by recognizing that the metoclopramide started this whole cascade, we really could get rid of the 4 drugs just by recognizing that. What is the best way to avoid the prescription cascade? Number 1 is to use only non-pharmacological methods to treat older patients. Number 2, to choose only medications that have been well studied in older patients. Or number 3, to treat each new symptom as an adverse effect of a medication until proven otherwise. For those of you who said number 3, that is correct. Number 1, it would be very difficult never to use medications in our older patients, so although that would be very nice to do and certainly something that we try to do, not really very practical. Number 2, we do know that most medications are not originally studied in older patients. So drug companies do not sponsor studies too often that include a lot of older patients. So that also is very difficult to do, to choose only medications that have been well studied in our older patients. So number 3 is what I consider the best way to avoid the prescription cascade. And that idea is every time somebody comes up with a new symptom, think about, could that be a side effect of a medication? So rather than treating that symptom with another medication, that we actually come up with a different way to treat the original issue, whether that's a different medication or a non-medication way to treat that original condition. I just wanted to also mention to you a little bit about resources. I have on this page 3 resources, which I think if you read these 3 resources, it gives you a very good overview of which medications are more likely to cause problems in older patients. So we have the Bears list, just updated in 2019, and we have the companion article to the Bears list from 2015, which actually gives you alternatives to those medications. And then we also have the stop and start criteria, last updated in 2015. In conclusion, older patients often have side effects of their medications. You may not be knowledgeable about all the side effects of medications, so remember to include your pharmacist on the team to help do medication reviews to optimize patients' care.